SAPIEN's Medtronic CoreValve. They are highly different in design, size, and deployment mechanisms. SAPIEN valve is expanded by balloon force. CoreValve is self-expanding. The SAPIEN valve come in sizes of 23, 26, and 29, and the recommended annulus dimensions are as marked here. CoreValves come in sizes of 26, 29, and 31. The recommended annulus sizes are like this. Above all things, annulus sizing is the most important thing, because if we deploy the undersized prosthesis, the device migration, paravalvular AR, and the prosthesis mismatch is worried. When it comes to undersized prosthesis, vascular access complications, underexpansion, and aortic rupture are worried. Basically, we have measured annulus two-dimensionally with the TT and TE. During systole, the distance between the basal attachment point of each leaflets are considered annulus diameters. 2D TE measured annulus was higher than that of TT. This shows significant difference may exist between annulus dimensions determined by TT and TE. Compared to CT, there is also a significant difference between the annulus dimensions determined by CT and echo. Annulus sizes were compared between TT, TE, and CT. Comparing each methods, the correlation was good, but there was some larger differences between CT and TT, CT and TE. In this study, comparing the predictive value of annulus dimension for paravalvular leakage between TT, TE, and CT, the correlation agreement between CT and TE was only modest. A decision based on CT would have modified the TAVR strategy in a large number of cases. Anyway, implantation was performed based on TE measurement, and it was successful in all but one patient with significant regurgitation. In their conclusion, in the absence of gold standard, a strategy based on TEE measurements provided good clinical results. Seen in 3 dimensions, aortic root is composed of 3 virtual 3 rings and 1 crown-like ring. From the sinotubular junction, each leaflets are attached through the length of aortic wall in crown-like fashion. The base of each leaflets are virtual ring formed by joining basal attachments of aortic valve leaflets. This virtual ring is annulus. From a CT image, we can see the annulus is elliptical in shape. Sagittal and coronal diameters are different. This is one reason why there is a difference between annulus measurement of echo and CT. There's also hazard of not measuring the full diameter of annulus if we measure it through the traditional sagittal view image. That is to say, annulus is complex 3-dimensional structure, and it is elliptical in shape, so any single dimension cannot adequately characterize annulus size. Then, how can we measure the annulus? 3D imaging modalities such as 3D TE and CT have been suggested to solve this problem. Cross-sectional CT can measure the diameters and area informations of annulus. With 3D TE, multiplanar analysis of 3D volume can make it possible to measure the diameters and area informations. In this study, annulus was compared between 2D TE, 3D TE, and CT to predict paravalvular AR. Compared to 2D TE, cross-sectional CT and 3D TE have greater areas under the curves in predicting paravalvular leakage. In their conclusion, 3D TE was superior to 2D TE in predicting paravalvular AR. Comparing each modalities, CT, 3D TE, and 2D TE were in order of superiority in predicting paravalvular AR. They recommended that cross-sectional data should be sought from 3D TE if good CT data are not available. In addition to annulus measurement, aortic valve calcification, coronary ostial height, and aortic root dimensions should be sought as well. About calcium, calcium extent severity, location, and asymmetry were thought to be predictor of paravalvular AR and other potential procedural outcome. Some aortic valve calcification studies showed echocardiographic usefulness to predict paravalvular AR. Because coronary ostium might be compromised during TAVR, valve calcification, location, eccentricity, bulkiness, and distance from the supposed stent seating should be sought by 2D and 3D echo. Sometimes sigmoid-shaped basal septal hypertrophy can make it difficult to the stent deployment position. In this case, we could keep watching if the stent moves or not during deployment. Fortunately, the stent was well positioned without significant movement. This is my last slide. For good TAVR results, we should understand the morphology of aortic valve and its associated structure, as well as interaction between this anatomy and the particular device under consideration. Aortic valve annulus is complex three-dimensional structure, and annulus is elliptical in shape. So any single dimension cannot adequately characterize annulus size. With TT and TE, sagittal diameter information has been traditionally and empirically used to guide annulus dimension measurement. 3D TE is better than 2D TE in predicting paravalvular AR. Cross-sectional data should be sought from 3D TE if good CT data are not available. In current practice, operators would get comprehensive information from echo and CT together and make their decisions in device and its size selection. Thank you very much.